Hi, it's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question from one of our readers, and the question last week was, what is an arterial blood gas test, also known as ABG? You can check out last week's question by clicking on the link below this video. In today's episode of Your Questions Answered, I want to answer succeeding questions from one of my clients, Anna, as part of my one-on-one consulting and advocacy service. Anna's dad has been transferred to a peripheral ward with low visibility in the respiratory ward after an ICU stay, and Anna is concerned about the care her dad would get from the medical team. So today's question is, my dad is still vulnerable and needs a higher level of monitoring. Why did they put him at a spot far away from the nurse's station? So today's email consultations with Anna are succeeding consultations that we published previously in the last few weeks, so you can go back and read those other consulting sessions as well. So in an email exchange it starts, "Hi Anna, thank you for the update. I'm very sorry to hear that your dad has gone backwards. Do not give up. Recovery after ICU is often 2 steps forward and 1 step back. Please read my comments below from your email. Also, I am not sure if I mentioned this to you, Anna. I own and operate a home care nursing service, Intensive Care at Home, where we basically send intensive care nurses into the home for ventilated, tracheostomized and medically complex patients. This is most likely not what your dad will need going forward, but I also have lots of experience in home care and I can help guide you what level of care your dad will need at home, including equipment." So then Anna writes back, "Hi Patrick, my apologies for taking so long to reply. Your email was so helpful as ever and gave me the information to challenge my dad's care. We fed back all of our concerns building from your advice to the rehabilitation board matron and one of the ICU matrons separately and together. The ICU matron, who's very pleasant, just talked the talk. Her response was to say our feelings were very understandable and kept saying that we were going through what every family goes through when their loved one leaves ICU. We politely reminded her that not every patient is like our dad, and not every patient has spent 3 months in ICU and battled sepsis, multiple organ failure, 7 cardiac arrests, delirium, critical illness, myopathy, weaning from a ventilator and tracheostomy. That he still has respiratory issues, including pre-existing COPD, and he needs quality intensive physiotherapy." Yes, Anna, definitely. That is why your dad needs to stay on the respiratory ward for now. And then Anna says that he's still vulnerable and needs a higher than basic level of monitoring, that he was not in a high visibility bed. The matron didn't really have an answer apart from direct us to the rehabilitation ward matron. To answer your question, ICU don't have a formal liaison or outreach nurse. It's done informally, we were told, which of course suits them and not the patient. The devil is always in the detail, as you have counseled me over and over again. And now that is very concerning, but that's why it's good that he's now on the respiratory ward. And Anna, as I mentioned to you previously, most ICUs have an outreach or an ICU liaison service. When patients get discharged on the ward after a long ICU stay with ventilation, tracheostomy, ICU needs to see them at least once, twice, sometimes 3 times a day to make sure they can stay out of ICU. And I wouldn't be satisfied to have an informal ICU outreach service. The more formal the service, the better the outcomes. Then from Anna continues, "Are you checking in with the rehab board?" We asked the ICU matron. "We have to be careful not to step on anyone's toes," she told us. I said, "But that doesn't have to be an issue if done respectfully. Our concern is that, and that should be our universal concern too," we replied. Well, Anna, from my perspective, that is a ridiculous comment to make. This is about your dad and not about hospital politics, because that's what it sounds like to me, that it's about hospital politics. Then from Anna. Fast forward to the day before yesterday. Dad ran a temperature, was short of breath, and said he had a violent coughing fit, bringing up a lot of mucus, which he almost choked on. He said it frightened him. He asked the auxiliary to get the doctor. The doctor reviewed him and phoned the respiratory ward, who said immediately to transfer him. He was transferred that night, placed in the high dependency respiratory part of the unit, put on higher oxygen and monitored all night. As he remained stable, they moved him to the acute respiratory bay within the unit. They confirmed to us he had developed an infection and are treating him with strong antibiotics. And now this sounds like this is a much better environment to begin with. At least they are allowing him to have a higher level of care when he needs it. This means your wishes have not fallen on deaf ears. They are treating him with antibiotics, and that is fine. He's in a much better environment now. From Anna. Patrick, this is exactly what we worried would happen to Dad, based on part on what the ICU consultant had cautioned against, but also based on our instincts of him being discharged from ICU too early to a general ward. Not only that, Anna, also having auxiliaries and not nurses on the ward probably got him to this point. There are nurses on the respiratory ward and not auxiliaries. That is a massive concern. If someone that's come from a prolonged ICU stay and is being looked after by auxiliaries, that is just such a big red flag that you almost should run 1,000,000 miles. A hospital ward needs to be staffed by registered nurses and not by auxiliaries. Anna says he needed time to consolidate his wins, and we felt it was likely he would have another setback based on what we knew of his pattern, and that this could be supported effectively in an environment where he was monitored appropriately. We didn't see it in a negative way, just that he needed to be in a space where they could act appropriately if needed. Absolutely, Anna. Make sure they keep him on the respiratory ward for as long as possible. This sounds more of what he needs. Patrick, this was not the rehab ward where most of the time it was often one auxiliary to 6 patients. It wasn't fair on Dad or on the auxiliaries. It concerned us that Dad was directly opposite the toilet, used frequently to empty commodes and by other patients. To be candid, it often smelled, so we worried about the airborne bacteria, and the wall dirty linen basket was against the wall near his bed. We felt this was far from ideal. And that is definitely a high infection risk to be opposite the toilet. From Anna. My dad then desaturated briefly in the respiratory unit after a mucus plug, and the ward sister told us he needs to stay there now. She said he will now be under the care of their unit and the respiratory consultant until he discharged, with the physios visiting or to a community hospital also setting for further rehab. She said that the myopathy is important to treat, but that his respiratory issues are the priority. They plan to do a CTPA scan to give an in-depth view of his lungs and to screen for any clots, which hasn't been done before. That is a good sign, Anna, that they are not giving up on him and do what is required. Patrick, they said he will get physio from Monday to Friday, and that they have a chest physio on call 24 hours again. Anna, that's exactly what he needs, and a good hospital has a physiotherapist on call 24 hours a day, including weekends. Anna says, the respiratory doctor and sister told us that they want to really move forward with Dad eating and drinking so that the feeding tube can be removed. Well, Anna, that is way overdue. What about speech therapy and swallowing assessments to get the feeding tube removed? From Anna, they said if Dad ever deteriorated, they would escalate him to the HDU part of the unit and get ICU in to review him. Again, Anna, a sign that the hospital listened to your wishes. Anna says they were positive, saying they think this is the best place for him and that it shows his strength and capacity to live and recover. One of the nurses yesterday mentioned to me that they are looking to wean Dad from the suction tool that he's getting reliant on it now and that they want him to get used to coughing secretions into a tissue, etc. As you know, he has a strong cough. Does this sound okay to you? Yes, Anna, coughing into a tissue would be great rather than suctioning. Best wishes. Okay, this one-on-one consulting session will continue in the next episode, over the next few weeks. So, how can you become the best advocate for your critically ill loved one? How can you make informed decisions, get peace of mind, control, power and influence quickly whilst your loved one is critically ill in intensive care? You will get to that all-important feeling of making informed decisions, get peace of mind, control, power and influence quickly when you download your free instant impact report now by entering your email below. In your free instant impact report, you will learn quickly how to make informed decisions, get peace of mind, real power and real control, and how you can influence decision making fast whilst your loved one is critically ill in intensive care. Your free instant impact report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free instant impact report now by entering your email below. In your free instant impact report, you will learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions, discover the many competing interests in intensive care and how your critically ill loved one's treatment may depend on those competing interests. How to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You will get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power, and influence in your situation. You will get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You will get crucial behind-the-scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also have a look at our blog section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Also, have a look at our membership site intensivecaresupport.org for families of critically ill patients in intensive care. You can also call me, find phone numbers on the top of our website. Also, have a look at our ebook section where you get more ebooks, videos and audio recordings, and you can also get one-on-one consulting and advocacy with me over the phone via Skype and via email by clicking on the relevant tabs on the top of the website. This is Patrick Hutzel from intensivecarehotline.com, and I'll talk to you in a few days.